just ordering some alpha-lipoic acid here. If I do this conference again, I'm going to insist that I go before Jimmy, because that was one of the best talks I've ever seen. You should be doing stand-up. That was great. Okay, so my name is Mike Mathier. I'm a cardiologist. I work here at the University of Pittsburgh. My main specialties are heart failure and heart transplant. So I see a lot of sarcoidosis patients who have any evidence of weakening of the heart muscle or involvement of the sarcoidosis in the heart muscle. And I'm also a pulmonary hypertension specialist, and so we see a fairly sizable number of sarcoidosis patients who have high pressure in the pulmonary vessels as part of their pulmonary manifestations or lung manifestations of sarcoidosis. So these guys asked me if I would talk about cardiac sarcoidosis and give you a sense of how we think about it, what we look for, etc. So some fun facts, not very fun I'm afraid, but I wanted to give you guys just some top-line pieces of information about this particular condition. So if you look at all patients who have some kind of a diagnosis of sarcoidosis, this is typically lung, skin, eye, etc., clinically speaking, in other words, what's apparent to the patient or what's apparent to the physician, in my case the cardiologist, 5% of those patients will have evidence of sarcoidosis in the heart. So in that respect, it sounds like it's relatively rare if 95% don't. But if you look instead at a couple of studies that did routine high-level imaging in patients who have sarcoidosis outside of the heart, it looks like more like 20 or even 25% of patients might have some evidence of sarcoidosis in the heart, even if it's clinically silent. And then there's been some autopsy studies that suggest that the incidence might be even higher. In the Japanese literature, the incidence has been reported to be as high, believe it or not, as 80%. But nobody else in the world has reported that. And it raises the question, of course, of whether the genetic makeup of the Japanese population somehow makes them more predisposed to heart involvement. In the standard US population, we think that the highest percentage that is likely to have clinically important sarcoidosis in the heart is probably somewhere between 5 and 20%. The most common thing we see when sarcoidosis gets into the heart is a rhythm abnormality. And those rhythm abnormalities break down into either what we call heart block, where the electrical signal that starts in the top of the heart moves its way down to the middle part and then down to the two main pumping chambers. It gets blocked at some part of that pathway. You can also see rapid heart rhythms, like ventricular tachycardia, which is a very dangerous rhythm. You've seen it on TV if you watch Grey's Anatomy, or in the old days watch ER or something like that, where they say clear and they shock the person. That's usually something like ventricular tachycardia. Fortunately, not very common even in cardiac sarcoidosis, but it does occur. The second most common way that sarcoidosis affects the heart is through infiltration of the muscle in the main pumping chambers. And so we know that you get these granulomas, and sometimes they are very, very patchy, and you don't see a lot of change in the heart function, but sometimes you see specific regions of the heart muscle start to look like they're not working properly. We call that a regional wall motion abnormality, because that part of the muscle isn't moving the way the rest of the walls are. Or sometimes you get more of a diffuse weakening in the heart muscle, a so-called cardiomyopathy. Those tend to be the patients that I would see. Not a very common thing. Because the rhythm abnormalities are the most common thing that we see in the heart, we recommend that in patients who have what we call extracardiac sarcoid, that means anywhere in your body other than your heart, that you have some kind of routine rhythm monitoring, and that can be as simple as just getting an EKG once a year. Some people do it every other year. Some people take a more intensive approach, and they might put a Holter monitor on you, where you wear it home. It's like a little kind of Walkman thing, and they monitor your rhythm for 24 or 48 hours. And sometimes we'll do more of what's called an event recorder, which is a very small device that can record your rhythm for 2 or 4 weeks. Typically, if you feel something where you think your rhythm might be changing, you get some palpitations, feel your heart racing, feel some skip beats, some fluttering, etc., you hit a little button and it records that section of your heart rhythm. That comes back, goes into a computer which analyzes all of it, and then one of our rhythm guys looks it over and says, yeah, there's something there, or no, there's nothing there. So any of those strategies might be used as a way to analyze for a rhythm problem. The most common way we look at the heart muscle function is with an echo. How many of you guys have had an echocardiogram at some point? Yeah, well, that's how we make our money in cardiology, so I'm going to ask you all to get one when you're out in the lobby afterwards. And echo's okay in the sense that if you really have a significant amount of heart muscle weakness, or if you have a clear-cut wall motion abnormality, like I was saying, we can see that, but echo's really not very good in terms of being able to say in a sarcoidosis patient whether there is involvement in the heart muscle. And so we've been fortunate, I think, in more recent years to develop two imaging tools that are much better for this. One is an MRI scan, cardiac MRI, we call it CMR for cardiac MR, and another is a PET scan. The second one is not as widely available, much more specialized, but we're starting to see MRI scans be used with greater frequency and more routinely when we're looking to see if there is cardiac involvement. And I'll show you a couple of those when we go further. In the old days, before those scans were around, we would have to rely on biopsy of the heart. Biopsy of the heart is done with a catheter where we go typically in through the neck vein here, a very short route down to the heart. We do it under x-ray guidance. The catheter we use has a tiny little pair of jaws on it. We put it down into the right side of the heart and we angle it over to the middle wall of the heart, and we take just like a millimeter piece. We try to move the catheter around so we're sampling in a couple of different places, and we might take 3, 4, 5 pieces, all tiny, send it to the pathology lab. They do fancy staining, they look under a microscope at it, and if they see those granulomas, they can say, oh yeah, this looks like sarcoid in the heart. The problem with that is what we call sampling error. So sarcoid in the heart is usually very patchy, and it's super easy just to get 5 biopsies of totally normal heart. And it doesn't tell you that there's not really sarcoid there, which is why an MRI scan or a PET scan is better, because there's no sampling error. You see every bit of the heart muscle. You're not relying on basically getting lucky with the biopsy catheter. So let's do some cardiac anatomy. So sorry to take you back to high school science here, but I think it's important and when you think about how sarcoidosis affects the heart. And so what you see here is the heart's sliced open, and we've got the right side over here where my pointer is. We've got the left side over here. And what we're going to do is we're just going to follow the pathway of blood as it returns to the heart. So it comes in through either the superior vena cava, this is the big vein that drains blood from your head and your upper extremities, or it comes in from the inferior vena cava, and the blood comes into the right atrium. That's the top chamber on the right side of the heart. That's the location of what we call the sinus node. That's the main pacemaker in the heart. And so if you have sarcoidosis affecting the right atrium, you may well have block of the heart signal because that node is right there. Right below that is the tricuspid valve, and that goes down into the right ventricle, and the right ventricle is the pumping chamber that is responsible for pumping blood out through the pulmonary artery here in blue into both of the lungs so that the blood can pick up oxygen and get rid of carbon dioxide. Then the blood returns into the left atrium over here on the left side of the heart, through the mitral valve, down into the left ventricle. Now that's the real engine of the body. That's the one that pumps blood through all of your body except your lungs, out into the aorta, and then distributed throughout your body. So that's kind of the quick and dirty anatomy of the heart. So you can think about the heart in terms of the components that make up its function. So we just talked about the muscle that makes up the ventricles, the 2 bottom pumping chambers, and that make up the atria, the 2 top chambers. You have the valves, I pointed several of those out. On the left side, the mitral valve, and then the aortic valve, and on the right side, the tricuspid and the pulmonic valve. You have a series of vessels that the heart's involved with, some of them the coronaries. That's not shown on that previous diagram. We don't really show them here. But those are the ones that feed the muscle blood. But then you have the great vessels that leave the heart, and the one that's most important in sarcoidosis is the pulmonary artery, because again, a fairly reasonable number of patients who have sarcoidosis in the lungs will develop some element of pulmonary hypertension, so that's a high blood pressure in this pulmonary artery. You have the electrical system. I talked about the sinus node, that's the pacemaker up at the top right, and then you have the electrical wiring that goes down through the middle part of the heart and then branches out into either of the pumping chambers. And then lastly, you have the pericardium, which is the sac around the heart, which sometimes can be involved. So So if you take each of those components, this is how sarcoidosis can affect each of them. So we know that in the muscle of the ventricles, or even in the atria, you can see these granulomatous infiltrations. So these are basically white cell infiltrations that are typical of what you see with sarcoidosis in other parts of the body. And as I mentioned earlier, that can create wall motion abnormalities or even cardiomyopathy if the patient has it more broadly throughout the whole pumping chamber. The valves occasionally get involved with sarcoidosis, but not often, and probably most of the time they're involved, it's because the muscles that hold the valves in place, it's because they're involved, and so they just don't hold the valves properly. The vessels, I mentioned the pulmonary hypertension part of this. This is something that I see a fair amount of. Pulmonary hypertension can be not only commonly seen in people who have lung sarcoidosis, especially if it's advanced, but it confers a worse prognosis, and so we have to attack it really aggressively. So we use some very specialized medications for that I'm not going to go into, but if you guys are interested and you want to talk about it later, I'll be happy to do that. The electrical system is a big part of what we look for with these blocks and these rapid rhythms. And then occasionally the sac around the heart will be involved with something like pericarditis, which means inflammation of that sac, which can be painful. It can cause fluid buildup inside the sac. That can compress the heart, a condition that we can call tamponade sometimes, and that can be concerning. So how do we make the diagnosis? So there's two ways to think about making the diagnosis. The first is you start with somebody who's got sarcoidosis somewhere else. This is by far the most common that we see. So somebody who's being followed in the pulmonary clinic with lung sarcoid, and they start to develop something that suggests cardiac involvement. And so this is the schema that we use in a patient like that. So point A is that there is some evidence of extracardiac sarcoid already been diagnosed, usually in the care of somebody who specializes in sarcoidosis. And then point B, you can have any of these things that are listed here. So it might be that you just develop a cardiomyopathy, weakening of the heart muscle, and it responds to an immunosuppressant challenge. So in other words, the sarcoidosis specialist says, they're developing some fluid buildup. I'm going to do an echo. The echo shows that their pumping chamber is weakened, so their ejection fraction is decreased. And we make an assumption that that's sarcoid, and we give enhanced steroid therapy or another immunosuppressant strategy, and then we see the ejection fraction improve and the heart muscle is strengthened. And you would then say to yourself, well, of course, that was cardiac sarcoid. That's why it got better when I treated it. You can see it if you've got evidence of some of these rhythm abnormalities that we talked about, whether it's ventricular tachycardia or heart block, or you can see it based on some of these other scan findings. So that if I had a patient who had had sarcoidosis outside of the heart, and they started to have heart symptoms, and I did an MRI scan, and it showed a classic finding for cardiac sarcoid, then that's good enough to make a diagnosis. We don't often go to biopsy anymore. And we don't go to biopsy very often because we are so susceptible to missing the disease with the biopsy. And now, of course, we've got these really nice scans that can almost always give us the right diagnosis. This is an example of an MRI, and what the little arrows show up in here is the classical finding, which is thinning of the septum, that's the wall between the two sides of the heart, way up by the valves. And that's an unusual finding in cardiology. You don't see that often, so when you see it on an MRI scan, it's pretty specific for being cardiac sarcoidosis. Not perfect, but pretty specific. If you back it up with the finding that there's something called late gadolinium enhancement, or LGE, you don't have to remember that because God knows I hardly remember it. But if you find that on an MRI, what it basically means is that area where the muscle had been healthy has now been replaced. Instead of having healthy muscle, there's kind of a microscopic scar tissue that we call fibrosis. And that fibrosis thins the wall down, and it makes it light up really bright on this second image down here. See how white that is? Instead of being dark like the normal muscle down here. So MRI scanning has gotten to the point where it's probably our cornerstone way to determine whether a patient with sarcoidosis has it in the heart. Now another struggle, this is really a tough one for us, is what if I have a patient who comes to me and they have no history of sarcoidosis anywhere else? And I have to recognize the possibility that they could have sarcoidosis in their heart muscle as their initial manifestation of sarcoidosis. Fortunately, this is very rare, and it's something I've only encountered. I've been in practice 20 years, and I've only encountered it, I think, twice in those 20 years. But the bottom line is you go through this algorithm where you have suspicion that somebody has heart disease, whether it be in terms of the muscle of the heart not looking normal or the rhythm of the heart not looking normal. Something raises your suspicion that sarcoidosis is possible. It could be the pattern that you see on the echo or something like that. It could be because the patient sort of mentions that somebody thought they might have sarcoid, but the diagnosis was never made. It could be just that your spidey senses are tingling, and it just happens to be something that you think about as part of what we call their differential diagnosis. And so we basically go through a process of ruling out common cardiac issues. We make sure they don't have coronary artery disease. God knows that affects way more in the population than sarcoidosis does, so we have to be aware of that. And then we look for evidence of cardiac sarcoid by these nice scanning techniques that we talked about. And then we would, to some degree or another, perhaps start a search for extracardiac sarcoid manifestations that may have just been missed. Maybe because the patient didn't notice them, or maybe because whoever they were working with as their physicians didn't realize that this was a manifestation of sarcoid. As all of you guys know, sarcoid can be a maddeningly challenging diagnosis. It does not necessarily come in with a neon sign saying, hey, I'm sarcoidosis, right? So it gets missed with some frequency. So that would be a way that we would get to a diagnosis of isolated cardiac sarcoid. In terms of therapy, it's a lot like what Ginny was just talking about, and I'm not going to go into the details because what we typically do in cardiology, because we see relatively few patients with sarcoidosis in the heart, is we work hand in hand with a sarcoidosis specialist. In my world, I work with Dr. Gibson, and we talk about the likelihood that this patient has cardiac sarcoidosis, and then we plot a strategy together about how we are going to use immunosuppressant medications to try to take down the inflammation in the heart and get it under control. So that could be higher dose steroids, usually for relatively prolonged time, 6 months, 12 months, sometimes beyond. Often these days, starting to introduce steroid-sparing medications at some point during that course, because obviously we don't want to have patients on high-dose steroids for all that time. And with that combination, we actually have pretty good success rates in controlling this disease. You can see that 10-year survival, which is about as far we can look into the future for cardiology, is well over 80% with aggressively treated cardiac sarcoidosis. If the patient is so sick that by the time we find that they have overt heart failure, I'm talking about where the heart muscle is really weak and they're struggling with a lot of fluid buildup, a lot of poor blood flow, unfortunately then the prognosis is worse because heart failure, as the name implies, doesn't carry a great prognosis. We still attack it very hard with a combination of both immune medications and specific cardiac medications, but you do have to recognize that if the disease process has gotten to that point where the heart's really weak, sometimes it's hard to get that back. Now in terms of heart block, we will see a patient with cardiac sarcoid where their primary manifestation is the block in the cardiac signaling, which produces a slow heart rate. We can see that on EKG or on monitoring. We'll treat them with immunosuppressant medications as well. And often when you do that, the heart block seems to go away. Unfortunately, there is enough concern that it could come back in the future that the recommendation is typically that even if you have a good response to, say, steroid therapy, we generally recommend the pacemaker as well. Pacemaker is such a routine part of what we do in cardiology, has an incredibly low complication rate. These devices can be incredibly long-lasting and very safe. And so, given the risk of down-the-road heart block, often the recommendation is to put a pacemaker in anyway. Now, this is a tough little algorithm to read, but it gets at the question, well, if the other rhythm problem besides heart block are these dangerous rhythms, the VT, the clear, I'm going to shock them kind of rhythms, should patients with cardiac sarcoid get an ICD, an implantable cardiac defibrillator? And what we do is we take sort of a step-by-step approach to try to understand that patient's individual risk for having a dangerous heart rhythm. And I'm sorry if you guys can't read this well, but I'll just walk you through it. The top one says that if you have had what we call, and forgive me because it's a terrible name, what we call sudden cardiac death, where you basically have had a fast rhythm like VT and you're out and you're lucky enough to get resuscitated by somebody, then you're going to get a defibrillator if you have cardiac sarcoid. We are never going to take the risk of leaving you unprotected without a defibrillator, no matter how you respond to treatment. Or if you have persistent weakening of the heart muscle with an ejection fraction under 35, that is an indication for a defibrillator, because we know patients with weakened heart muscles have a higher risk for ventricular tachycardia. And then down through this middle section here, we have what I would call sort of intermediate situations where we may recommend a defibrillator or not. Some of this has to do with, on a monitor, do we see a lot of ventricular tachycardia that stops all on its own? And if we see a lot of it, does that predict that you might be at risk for a ventricular tachycardia episode that doesn't stop in the future? We often think yes, and that may be enough for us to put a defibrillator in. Are we putting a pacemaker in anyway? And since every defibrillator has pacemaking built into it, should we just go ahead and give you the Cadillac that is both a defibrillator and a pacemaker all at once? And often we'll do that because risk assessment is imperfect. I can give you a ballpark of what your risk might be in the future, but goodness knows I don't have a crystal ball. I don't know what it's going to be for sure. And so it might be worth just saying, let's go ahead and put a defib in so that we have that protection. And really, only if you get down to the very low-risk situations where the heart muscle isn't bad, we're not seeing a lot of ventricular tachycardia on monitoring, you haven't had episodes of passing out or documented VT episodes in the past, then we would feel comfortable saying, you know what, a defibrillator is just not indicated here. You're not at high enough risk. And it's a very careful decision-making process that usually would bring in a team of physicians, so not unusual for us to have Dr. Gibson be the primary sarcoidosis doctor, me being kind of the cardiomyopathy doctor, and then bring in an electrophysiologist who's the rhythm doctor, and us to confer on the one patient and come up with a recommendation. So I'm going to summarize just by saying that clinical cardiac sarcoidosis appears to be rare, but I think we all have to be aware of the fact that we might be missing some of it. These studies that have done more routine imaging suggest we might. On the other hand, I don't think we're in a position where we can say everybody who has any manifestation of sarcoidosis should get an MRI scan. MRI scans are really expensive. And so it's not necessarily the right conclusion to say, because we see it more frequently if we MRI scan everybody, that we should MRI scan everybody. We believe that a lot of times diseases can affect the heart and they just kind of go away on their own, and nobody's the worse for wear. And so for now we go with our kind of screening testing that I pointed out here. The most common manifestations, again, that we really look for are rhythm issues, either block or fast rhythms, or cardiac muscle involvement, either wall motion abnormalities or cardiomyopathy where there's generalized weakening of the heart muscle. The new imaging scans, whether it's cardiac MRI or PET scanning, which I didn't really talk about, have been an enormous advance for us. We have much greater precision than we used to. We don't have to do biopsies, which were always frustrating anyway because we never knew whether we were missing it. And so I think that we're able to give patients a lot more certainty about whether they have this particular manifestation of sarcoidosis. And with medical treatment, with or without a device being pacemaker and or defibrillator, patients with cardiac sarcoid, for the most part, do very well. Unfortunately, we have some that come very late in the disease course, and they don't do as well. But if we catch it pretty early, which is why we do the screening, then we tend to have good outcomes. So I'll stop there. Thank you, guys.